everyone. I am Dr. Saida Khadija Fatima, Assistant Professor in the Department of Pathology, and today we are going to discuss gastrointestinal pathology. The topics which will be covered today will be esophagus, stomach, small bowel, large bowel, and appendix. The diseases of the esophagus are classified into tracheoesophageal fistula, esophageal diverticula, achalasia cardia, hiatal hernia, esophageal varices, inflammatory and other related disorders of the esophagus, and esophageal tumors. Symptoms of esophageal disorders are classified into dysphagia, heartburn, hematemesis. Dysphagia is difficulty in swallowing. This is attributed either to deranged esophageal motor function or to narrowing or obstruction of the lumen. Heartburn is also called as retrosternal burning pain, and it usually reflects the regurgitation of the gastric contents into the lower esophagus. Less commonly, hematemesis, that is vomiting of blood, and melena, which is blood in stools, can occur as an evidence of severe inflammation or ulceration or laceration of the esophageal mucosa. Massive hematemesis may reflect life-threatening rupture of esophageal varices. Coming to the normal anatomy of esophagus, it is a tube structure extending from C6 to T11 or T12 vertebra. The length of esophagus is 25 cm in an adult on an average. 3 points of luminal narrowing are present in the esophagus. The first one comes at the cricoid cartilage. The second is where the left main stem bronchus crosses anterior to esophagus. And the third is at the diaphragmatic opening. Upper and lower sphincters are defined manometrically, means they exert a pressure over it. But there are no morphological landmarks. Outer longitudinal muscle layer on microscopy is striated for the first 6 to 8 cm. So it is a striated kind of voluntary muscle just up to first 6 to 8 cm. Serosa is absent on the esophagus. So the lesions of esophagus like suppose esophageal cancer can spread easily into the mediastinum. This is the normal histology of esophagus, showing a lining of non-keratinized stratified squamous epithelium, and below that the stroma contains mucous glands and some inflammatory infiltrate, which is mostly lymphocyte. Few congested vessels are seen in a fibrocollagenous stroma. Here we can also see muscle bundles. Coming to the congenital anomalies of the esophagus, tracheoesophageal fistula is a congenital disorder which is suggested in a newborn baby by copious salivation associated with choking, coughing, and cyanosis on attempts of food intake. It occurs in 3 distinct variants. The most common one is where the lower portion of the esophagus communicates with the trachea near the tracheal bifurcation. So coming to the picture, this is the C type of tracheoesophageal fistula where the lower part of the esophagus will communicate with the trachea and the upper part will end in a blind pouch. The upper esophagus ends in a blind pouch which is called as esophageal atresia. Maternal polyhydramnios, which is also called as increased amniotic fluid, is a frequently associated abnormality. So the most common one is where the upper esophageal end ends in a blind pouch, and it also occurs in polyhydramnios. The second most common variant is characterized by a fistulous connection between upper esophagus and the trachea. The lower esophagus segment is not connected to the upper esophagus. So this is the P type of tracheoesophageal fistula. The third variant is a fistulous connection between the trachea and a completely patent esophagus. So the E type. Esophageal diverticula are pouches lined by one or more layers of esophageal wall. So most commonly it is a false diverticula, which is also called as pulsion diverticula. So this results from herniation of the mucosa through defects in the muscle layer. Okay. Less commonly, it is also called as true diverticula or traction diverticula, which can occur, and this consists of all the three layers, which is mucosa, muscular layer and serosal layer. Serosal layer is initially absent in the beginning, but when you go down it appears. So all the three layers will be present in a true diverticula, and in false diverticula only one or two layer will be present, mostly because of herniation of the mucosa through the muscular defect. So it's just a mucosal protrusion. Traction diverticula result from periesophageal inflammation and scarring. Esophageal diverticula occur in three characteristic locations: immediately above the upper esophageal sphincter, which is called as Denker's diverticula, near the midpoint of the esophagus, and immediately above the lower esophageal sphincter, which is called as epiphrenic diverticulum. Achalasia cardia is a term given to failure to relax, and here it denotes incomplete relaxation of lower esophageal sphincter. So this sphincter remains patent almost always and in response to swallowing. So what happens here is, whenever we swallow, normally the esophageal sphincter will relax so that food can go inside the intestines. Now if there is incomplete relaxation of the lower esophageal sphincter, food cannot enter the stomach. It will stay inside the food pipe. So this produces functional obstruction of the esophagus with consequent dilatation of the proximal esophagus. So the proximal esophagus will dilate rather than distal. The condition is caused by a loss of ganglion cells in the myantric plexus. So this is a plexus of ganglia in the muscle layer. So if that is lost, then the contraction stimulus will be lost. That's why this leads to progressive dilatation of the esophagus. One important source here is Trypanosoma cruzi infection in Chagas disease. In other cases, ganglion cells are lost for reasons that are unknown. Clinical characteristics include difficulty in swallowing, and achalasia can lead to esophageal squamous cell carcinoma in about 5% of the subjects. So this is how achalasia cardia will occur, where there will be a dilatation of the proximal part of the esophagus. Hiatal hernia is different from the achalasia cardia, where a part of cardiac part of the stomach will come above the diaphragmatic opening of the esophagus. Hiatal paraesophageal hernia is the esophagus remains normal and the esophageal opening also will remain intact. Lower esophagus will also be functional, but the opening in the diaphragm will be dilated, because of which a part of the stomach will be lying parallel to the esophagus. Hiatal hernia is a sac-like dilatation of stomach present above the diaphragm. It is of two types, sliding and rolling type. Sliding hernia is the most common one. It is congenital disorder where congenitally short esophagus or acquired from esophageal scarring induced by traction on the stomach will pull the stomach above the diaphragm. This predisposes to reflux. Rolling or paraesophageal hernia is seen in 10% of the cases, and here a portion of the cardia protrudes through the diaphragm into the thorax alongside the esophagus. It is vulnerable to strangulation and infarction. Strangulation means they will be dying or death of the tissue because of constriction of the vasculature, and infarction is necrosis of the tissue because of ischemia. Coming to esophageal varices, these are dilated submucosal esophageal veins. They occur secondary to portal hypertension and can result in upper gastrointestinal hemorrhage. The other important cause of upper gastrointestinal hemorrhages are bleeding peptic ulcer and Mallory-Weiss syndrome. Inflammatory and other related disorders of the esophagus include gastroesophageal reflux disease or GERD. This is reflux of the gastric acid contents into the esophagus. Characteristic manifestation often includes substernal pain relieved by antacid. Most commonly associated conditions are hiatal hernia, incompetent lower esophageal sphincter, excessive use of alcohol, tobacco, increased gastric volume, pregnancy, scleroderma, and recumbent position. Morphology wise, the microscopic picture will mostly be composed of a non-keratinized stratified squamous epithelium showing inflammatory cells intraepidermally. We can see eosinophils, we can see lymphocytes as well as neutrophils in the epidermis. The mucosa of the esophagus, and submucosally also inflammatory cells will be seen. So this is a feature of esophagitis, which is inflammation of the esophagus. Gastroesophageal reflux. What are the major complications of the reflux esophagitis then? It is ulcer, it is bleeding, it is stricture formation and development of Barrett esophagus. So what is Barrett esophagus? This is columnar metaplasia of the esophageal squamous epithelium. So esophagus is lined by, mucosa of the esophagus is lined by squamous epithelium. So when it converts into columnar epithelium, it is called as Barrett's esophagus. The columnar epithelium is often intestinal type. Why are we saying intestinal here? Because columnar epithelium can be of other types as well. Intestinal type is characterized by prominence of goblet cells. Occurring in as many as 5% to 15% of persons with persistent symptomatic reflux disease, Barrett esophagus affects males more often than females, and it is much more common in whites. This condition is a complication of long-standing gastroesophageal reflux. So this is a precursor or a precancerous lesion. Barrett esophagus is apparent as salmon pink velvety mucosa. So here the pale pink esophageal mucosa is the squamous epithelium, and normally we have a columnar epithelium of the stomach. Now if usually there is a sharp demarcation between both at the lower esophageal junction. But what happens here in Barrett's esophagus, you can see some creeping velvety mucosa here, which is slightly like salmon or fish flesh in color, and the lining also becomes irregular here. And here you can see as a lush light brown gastric mucosa. So this is how the squamous epithelium, which is not keratinized, so this is the squamous epithelium of the esophagus mucosa. Now this might be a junction of the gastric and the esophageal mucosa, which is now being replaced by goblet cells and intestinal cells. Basically, intestinal epithelium with columnar cells as well as the goblet cells. So that gives it intestinal type of columnar epithelium. Other causes of esophagitis includes Candida esophagitis, which is also called as moniliasis. Associated conditions often include antibiotic use, diabetic mellitus, malignant disease, immunodeficiency. So since Candida is an opportunistic infection, it occurs in all these immunodeficient states. Herpetic esophagitis is caused by HSV1 infection. Characteristics include painful and difficult swallowing. Less commonly, you can find a cytomegalovirus infection, uremia, and radiation therapy as a cause of esophagitis. Coming to the esophageal tumors, leiomyoma is the most common benign tumor of the esophagus arising from smooth muscle cells. Squamous cell carcinoma is the most common, usually common in the China and rare in the US. Here it is more common in males and more than 50 years of age males. Early carcinoma is called as a carcinoma infiltrating the submucosa, just up to submucosa, and doesn't go beyond it. So 90% 5-year survival rate is seen in early carcinoma patient, and that has a good prognosis even though lymph nodes are involved. This spreads locally into the mediastinal structures and to the lymph nodes. Clinically, early carcinoma will have insidious dysphagia, weight loss, anemia, and overall 5-year survival rate is just 5%. Risk factors for squamous cell carcinoma are esophageal disorders like long-standing esophagitis, achalasia, Plummer-Vinson syndrome. So this is a triad of esophageal webs, microcytic hypochromic anemia, and atrophic glossitis. Lifestyle includes changes like alcohol consumption and tobacco use. So these are the bad habits which can lead to squamous carcinoma. And dietary factors are deficiency of vitamin A, C, riboflavin, thiamine, and pyridoxine, deficiency of trace elements like zinc and molybdenum, and fungal contamination of foodstuffs, high content nitrites and nitrosamides in the diet. Genetically, tylosis is a condition where there is hyperkeratosis of palms and soles. So this leads to squamous cell carcinoma as well. Squamous cell carcinomas are usually preceded by a long prodrome of mucosal epithelial dysplasia followed by carcinoma in situ, and then finally the emergence of invasive cancer. So this will take months to years also. These become tumorous, taking one of the three forms. So it is of three types: polypoid exophytic masses, or necrotizing cancerous ulcerative masses, or diffuse infiltrating neoplasm. The necrotizing cancerous ulcerations that extend deeply and sometimes erode into respiratory tree, aorta, or elsewhere. Diffuse infiltrative neoplasm that cause thickening and rigidity of the wall and narrowing of the lumen. About 20% arise in the upper third of the esophagus, 50% in the middle third, and 30% in the lower third. This is how a squamous cell carcinoma will look like. This is a normal non-keratinized stratified squamous epithelium, somewhat thickened, lining the mucosa of the esophagus. And here you are seeing that part of the squamous epithelium is infiltrated the mucosa, has infiltrated the mucosa, and it is present in the form of a nest. So this kind of infiltration, that is nest formation in the submucosal region, is a characteristic feature of squamous cell carcinoma. This is how the polypoid and ulcerated lesion of the squamous cell carcinoma will look like. Esophageal adenocarcinoma, the incidence is 25% of esophageal cancers occurring worldwide. Up to half of all the esophageal cancers are reported in the US. Primary risk factor is the precancerous lesion of Barrett's esophagus. Most arise in the distal one-third of the esophagus. Histology-wise, it is a mucin-producing adenocarcinoma, and this also presents with dysphagia. Overall survival rate of 5 years is less than that of the squamous cell carcinoma, that is 15%. So this is how the mucosal glands of the esophagus can turn into a malignancy, where there will be proliferation of glandular structure lined by abnormal columnar cells. So this has a very closely packed increased gland to stromal ratio lined by atypical cells, and this is seen infiltrating into the other layers of the esophagus. Squamous cell carcinoma is more common than adenocarcinoma. Squamous cell carcinoma is more common in Asia, and it occurs in more than 50 years of age. The site of squamous cell carcinoma is middle one-third of the esophagus, and the site for adenocarcinoma is lower one-third of the esophagus. The risk factor for squamous cell carcinoma is smoking, alcohol, and foods, and for adenocarcinoma it is reflux esophagitis or Barrett's esophagus. 5-year survival rate is more for adeno, okay, not for squamous. For squamous it is 5%, and for adeno it is 15%. Yeah, for squamous it is less, and for adeno it is more. So adeno has a better prognosis than the squamous. So thank you so much for your patient listening. Kindly ask me any doubts if you have any doubts in the comment section. Thank you.